any one or all of those agenda items.
Thank you. Thank you. Good afternoon, Madam Chair and members. My name is Farah McDade-Ting from the California State Association of Counties. I'm testifying in support of the drug Medi-Cal waiver as submitted. The Department of Healthcare Services, from the director and Karen and Marlise, worked very, very hard on working with counties as well as providers and other stakeholders on the waiver. As it currently submitted, we support it, and we look forward to working through how CMS responds and then how counties opt in. I do want to reiterate again that it is an opt-in waiver, so all counties may not opt in, but we're looking forward to seeing what we can do under the waiver for the counties that do. Thank you.
Thank you. Next witness.
Madam Chair, members of the committee, I'm Dr. Jason Kletter. I'm with California Opioid Maintenance Providers. We represent 120 narcotic treatment programs, provide services to about 40,000 patients across the state. And I'm here to also provide my support for the waiver. We are encouraged by the provisions of the waiver. We certainly support the goals of the waiver that intend to expand access to residential treatment and use robust assessments such as ASAM. But we do have some concerns. We've been vocal about our concerns about the part of the waiver that waives beneficiary freedom of choice. That said, the department has worked very closely with us. They've been very generous with their time, spent a lot of time and energy with us crafting some language that we think will be very helpful in ensuring continued access to treatment services. So we very much appreciate the department's efforts and the county's efforts to work with us on crafting that language. But we do think it's incumbent on all of us, the legislature, the department, counties, and providers to monitor closely to make sure that there are no unintended consequences that could result in a diminution of access. Thank you very much.
Senator Stone has a follow-up for you.
Doctor, no.
Yes, sir.
Thank you and your colleagues for the work that you do. I mentioned before about the armamentarium of drugs that are available to treat addiction, and I brought up Vivitrol, naltrexone. Can you just elaborate on your utilization of naltrexone, and are you having any issues of accessibility with your patients in receiving those drugs?
Thank you for your question. Most NTPs across the state do not use naltrexone for a variety of reasons, mostly because there's language in statute that allows us to use all FDA-approved medications that are replacement medications, I should say. So there's one word that I think was unintended, but it was inserted in statute, so it precludes narcotic treatment programs from using medications other than replacement medications. So for example, we can use buprenorphine or methadone, but we cannot use an antagonist like Vivitrol. So we'd love to get support from this committee to eliminate that one word, which we think would open up access to Vivitrol, to naltrexone in narcotic treatment programs.
So you believe amending and changing the language of that statute would give you the tools to better treat these patients?
That would go a long way. That would be part of it for sure.
If you could leave me your card, I would love to work with you on that.
Great. Thank you very much.
And as we move on in that same vein, is there a cost factor? I know this is off the top, but would the department have any response to that?
So I can give you a little response.
Where's your lifeline?
I'm here.
Oh, there she is.
So there is a big cost difference between the oral naltrexone, which is relatively inexpensive, and then the long-acting injectable is more costly, a lot more costly, and studies have shown that it's 4 times, you could treat someone with methadone 4 patients versus 1 with the Vivitrol. And there have been some issues with patient acceptance is very low with especially oral naltrexone, and also there's limited research on the long-acting injectable, but it takes 40 seconds to actually the really big shot, and then it's for a whole month. The beneficiary, like you had mentioned, cannot get any sort of high or anything, and patients don't tend to come back and get another shot. So there's a lot of things that we can provide more information on from the department. Those are just a few of the...
And we're happy to talk to our pharmacy section who's not here today, because between the drug Medi-Cal program and then Medi-Cal more broadly in terms of what we have on our contract drug list, there probably is some cost implications, but I'm not sure.
Well, I would look forward to working with you. Again, compounded products are not patent-protected drugs, and so you're paying for the cost of basically putting the ingredients together, which are very inexpensive. And there are formulations of injectable naltrexone that are actually compounded by pharmacies that are licensed to compound sterile products that have been recommended by physicians to use a different vehicle to deliver that drug in a sustained action mode that's different than Vivitrol may. So there could be some treatment alternatives that mimic and do virtually the same thing at considerably lower cost. And so I'm hoping to champion some of those savings. And because of the inexpensive availability of these drugs, we could be giving the tools to the doctor, like we just heard today, to make those treatments available to a lot more people and help them with their addiction modalities. So,
Thank you very much. Next witness, please, 2 minutes.
Well, now I get limited.
Everybody's
My
got the
name
same.
is Steve Mulhart, and I'm here actually representing Alcinella on behalf of the California Association of Alcohol and Drug Program Executives. We submitted a letter dated April 1st to the committee, and hopefully you've all had an opportunity to see that. There were 3 issues brought up in that. One related to the increase in the residential license fee. That's not being covered in today's hearing. The second item, timely certification. Our members continue to complain about the time lag that it takes to get through the PED process and get certified, even for existing good operators, time lags that last from a year to 18 months. And I think that under the waiver, it's going to be very embarrassing to us if we get a waiver approved and other states are watching us and we have a bottleneck that creates a delay in getting certified providers to provide those services that we're touting, because we're going to look kind of foolish. So we really need to work on staffing that properly, giving them the tools that they need to make some common sense sort of decisions and process this more quickly. And maybe put a little more heat on the IT solution that they're talking about, because that sounds wonderful, but you know, it's still 6 or 8 months away, and we're going to be into the waiver process before it gets field tested, and certainly be well into the waiver process before it's ready for prime time. The third item related to the waiver and the selection of the Bay Area as a starting point. And our concern is that Los Angeles really wanted to be part of phase 1, and a huge portion of the state population is there. And we really think that the department ought to consider allowing some counties to opt in if they really want to do that. And then if I might make a comment on behalf of Aegis Treatment Centers, which is my employer, we operate 25 NTPs. And to respond a little bit to Dr. Stone, our experience with naltrexone is that patients were very difficult to get them to comply with the oral naltrexone. As Dr. Clutter said, we have our hands tied a little bit. It's not a drug that's allowed to be used under the controlling regulations and statutes. We'd like to see that amended. We've been approached by some law enforcement folks with the idea of giving the people an injection before they leave prison or jail, and then having follow-up done by a community provider like us. We'd like to consider that sort of protocol, currently not in the cards. And the waiver really doesn't include Vivitrol. It includes buprenorphine and disulfiram, but Vivitrol has kind of been put to the side because it's $800 or $900 a month compared to $20 or $30. I'm fascinated with your reference to the compounded version. Maybe that's a solution. But I think we need to really have on the drug Medi-Cal formulary all of the drugs that we should be allowed to use, which includes methadone, disulfiram, naltrexone, extended release naltrexone, buprenorphine. They all need to be available to us. Those need to be our tools. And they need to be on the drug Medi-Cal formulary, not under a TAR with the pharmacy benefit or the medical benefit. It just makes it very difficult to manage. Thank you very much.
Thank you. Next witness.
Hi, Senators. My name is David Peters. I'm the Director of the External Affairs for an organization called the California Consortium of Addiction Programs and Professionals. It is a very recent merger of two longstanding organizations in this state that were called CAR and KDAC, and we're 6 months into our merger now, and we're doing really well. We represent treatment programs and counselors. We're also a counselor certifying organization, so I'll have something to say about item number 7. But for the items you're on right now, I want to echo Jason Kletter's remarks. We really appreciate a lot of work that was done at the department and with us as stakeholders in preparing the 1115 waiver. The ASAM criteria is really great. The IMD exclusion is really good. Rolling it out, I guess you can't make it through the whole state all at one time, but the Medi-Cal expansion population that this is targeted to is I guess all that enrollment backlog for the beneficiaries might be dwindling, but we want to get Medi-Cal certified, drug Medi-Cal certified, to meet the expanded population, to be able to take advantage of the waiver. And I don't know about what the process much is at PED. I know that they want some more positions, but the positions and the process kind of go hand in hand, and it sounds like the department's doing a lot on that, but our programs have gone a year in the attempt to get drug Medi-Cal certified, and eventually they just quit because it was just, something was going wrong and it was too cumbersome. But we really appreciate all the work on the waiver, and it's really going to help the population of the state. Thank you.
Thank you. Last witness.
Chair, members, Robert Harris on behalf of the California Society of Addiction Medicines, the doctors who treat people with addictions and also educate other physicians about people with addictions. The waiver is a wonderful thing. Some of our doctors were on a committee, worked really hard. The department did an incredibly good job with this. It's going to change things for a lot of people. It's going to make their lives better in California, and that's key. We also, just to go back to the discussion of buprenorphine and the TARs, it's been a problem, but the pharmacy division has actually worked with some of our doctors to make it incredibly easier than it used to be. Not having a TAR would be even easier, but at least it's more streamlined than it was, and so it's been really helpful, and they were helpful in meeting with our doctors and working out solutions for that. So I just want to, it's mostly kudos at this point, but yes, getting rid of TARs would be good, and rolling this 1115 out is a wonderful thing. I also want to say that there's been a technical problem about doctors working in treatment facilities, and the department's been more than helpful on trying to get us to a place where we can change that old thing in the law from the 70s. So thank you very kind.
Thank you. Would the department like to respond to any of the comments made? Public comment might be helpful.
I mean, I think I'd like to just say that out of the investigation and the details that were surrounding drug Medi-Cal, spring opportunities, right? The organized delivery system and the way that we're reorganizing drug Medi-Cal in general is, I think, as Mr. Harris just said, is going to really change a lot of things for a lot of people that need services in the right place and at the right time. The department has, both from a programmatic standpoint and from a program integrity standpoint, really struggled to address both the significant problems that were uncovered as a result of the investigation, but also we are acutely aware and mindful of the fact that there are a lot of really good providers out there that just want to be able to provide services, and finding that balance sometimes is challenging, and so we're struggling mightily to meet that need, while also ensuring that the individuals that were propagating some of the most egregious fraud in the department are certainly put away. And when you look at the chart that was in your briefing, the number of providers that are no longer with us is telling and significant. And so it's with that we still continue to press forward, and we believe that we are doing better by the program and better by the beneficiaries. I know that for you, Senator Stone, knowing your provider interest, I think we've already reached out to do a briefing with you on PAVE so that you can see some of the new whiz-bang bells and whistles. We've also eyeballed a couple of other providers in this building that we think will also appreciate it. So, bear with us. We know it's taking us a little bit of time, but we really ultimately struggle with balancing, making sure that beneficiaries that are in probably their most fragile and susceptible state are being treated by the providers who are there to do the right thing. So we thank you for that.
Thank you for that. And I look forward to getting together with you and learning about all the wonderful things that you're doing certainly to prevent fraud within the system, which is unacceptable in any county, state department. One thing that one of the speakers I thought was very compelling is when these people they're released from prison and they're given a shot of Vivitrol, and they're virtually guaranteed for a month that they're not going to be able to be enjoying the creatures of their habits in the past until they can get to a treatment program, I think is fantastic. And I think you made it very clear. The reason why we have a treatment authorization request for Vivitrol is because it's $1,000, okay? So if Vivitrol was a patented medication for which there was no other alternative to make that medication, a TAR would be absolutely appropriate. Otherwise, you could have a run on the bank in the state of California, and we have, we'd be looking at a $300 million allocation like we are for the drug for hepatitis C, which is a very important medication, and I support that we have it on formularies. But this is a situation where, believe it or not, in a sterile compounding pharmacy, you can make a version of naltrexone injectable sustained release for less than $100 a month. So if that is the kind of cost that is attractive and allows it to be used on a much more prevalent basis to curb people's addiction and save their lives and save their families, I hope that the state embraces the utilization of thousands of compounding pharmacies that exist in the state and the country that have the capability of satisfying some of these very important needs in our community. And I look forward to continuing those discussions with you.
Great, thank you.
Thank you very much. We'll move on to item number 7, the last item on Part A of our agenda today, Substance Abuse Recovery and Treatment Services, AB 2374 of 2014 statute.
Great. So last year, AB 2374 was put into effect and actually started in January of this year. And what this bill does is it expands the department's authority over our certifying organizations. So in California, we currently have 3 certifying organizations that certify our alcohol and other drug counselors. So we have about 26,000 in the state. So this grants the department authority to monitor and oversee the certifying organizations. It enables us to audit them. There have been some reports done by the Senate Office of Outcomes and Oversight that the department didn't have enough authority over these organizations. So this bill granted that authority. So the department is requesting 2 staff to conduct the audits and the monitoring reviews.
Any questions? Finance? LAO? Public comment. 2 minutes, please.
Thank you, Senator. Again, David Peters from CCAP, the California Consortium of Addiction Programs and Professionals. So this is a little difficult. I personally was involved with the Mansour bill from last year to help him rewrite it to clarify exactly what he was after, and I really appreciated his willingness to work with us. As I said, CCAP is one of the 3 certifying organizations, and what I would like to do, what I would like to urge the committee to do is hold this open. We would like to have a little more discussion with you. I know my legislative advocate had a meeting with Ms. Bass a couple of weeks ago, or this week, regarding our concern with the fee hike that was put in place last year by the legislature Our concern with it is essentially that the BCP from the department asked for $740,000 for 6 staff, I believe all for the compliance division. It turns out the fee schedule that was implemented raised a little over $3 million a year. If the compliance division needs more people, we fully support that, but I'm not clear at this point where the money is going to come from for the additional 2 positions for the certifying organizations. Part of the BCP last year did include some discussion about the requirement for monitoring certifying organizations and counselors and things like that. So I don't know if this is new money that they want, new positions in addition to the 6 that they got last year, but we're also concerned about the implementation of that fee switch around last year, because our residential treatment programs cost, licensing per bed cost more than doubled. All the other programs got a 10% fee hike. We didn't think it was equitable, and I know that that issue wasn't put on the agenda, but with more, another request for positions to oversee 3 COs, 2 whole positions to oversee us, I'd like to continue that discussion with the department and with all of you. So thank you for that.
Thank you very much for your comments, and it is the recommendation that this item be held open.